Okay, I think you can go ahead, Dr. Westley.
Okay, let me get my video up. It's a little dark. Not that everybody wants to see me anyway, but a little more light maybe. Okay, so thanks everybody. We're going to do our last 7th module today. We're going to talk about Clostridium, what used to be called Clostridium difficile, now referred to as Clostridioides difficile until they inevitably change the name again, as everything's name is changing. Here's our accreditation and disclosures. So what we'll do today is review briefly the current epidemiology of C. difficile diarrhea, identify evidence-based maneuvers to minimize risk, recognize best practice diagnostics, suggest initial therapies based on patient demographics, and advise providers on options for managing recurrent disease. So these are the guidelines. 2018 actually is a bit outdated now. Those are 7 years old, but those are the current IDSA guidelines. There's a brief focused update from 2021. There are also European guidelines and American College of Gastroenterology, and a nice review, which I've linked here in the references. So C. difficile diarrhea is diarrhea that occurs typically after antibiotic exposure and can cause pseudomembranous disease. There are different definitions for when that occurs and how we refer to those cases. Some of this is simply reporting data, but it's important when we look at epidemiology, for example. So healthcare onset means that disease starts in a hospital. Community onset, but healthcare facility associated basically means that diarrhea starts at home, but someone was recently exposed to a healthcare facility. And then there's community-associated disease, and there are strict definitions for reporting that we don't really need to get into. It's more of an IP thing, but these are broadly categories of disease. So in 2024, this remains a big problem, 500,000 cases, 30,000 deaths attributable. However, from 2011 to 2017, cases have trended down slowly, and many of our institutions have seen that, thankfully. Global rates overall in the last 30 years have risen, but in the most recent, same about 10-year period, they do appear to be starting to fall. This is just from one study that from Anaerobe this past year that shows that general trends overall are down, and that is really driven by healthcare associated disease, whereas the community levels, which are lower, have started to remain flat. So it seems like interventions we're taking in the hospitals, antimicrobial stewardship certainly among them, appears to be helping drive down overall rates. So who should be tested for C. diff diarrhea? So the guidelines in 2019 said if there's unexplained 3 or more unformed stools in 24 hours, and they're pretty liberal about it. Now, some systems have published algorithms on who to test, which we'll get to in a minute. We don't want to test everybody with a warm GI tract, so we want to limit that a little bit. And then, how do we use? We use multi-step testing, and the guidelines do sort of endorse doing this. So initially, you do a test that's very, very sensitive, that is going to find virtually everybody that has C. diff in the intestines. And then they say to add a second specific test, which is going to confirm infection, but not be able to rule it out so well. So it's a combination of a sensitive and specific test. And then the last test that is performed in the laboratory, even if it's on the same exact stool sample, but the last test that's actually run and documented in the chart actually determines what's reported to the safety network, the National Healthcare Safety Network, as a case. So this has actually, to a degree, driven why this testing happens this way. The guidelines are clear that in children under 2, there is substantial asymptomatic carriage, and testing should be avoided in that group, which rarely gets sick from this, and not to retest after a positive or retest within 7 days. So that 2-step testing we talked about, where you use a very sensitive test, but then add a specific test, has a substantial impact on how much C. diff disease. So you can see in this one study, there were several years of rising C. diff cases when using PCR or NAT testing alone. And as soon as they suddenly switched to two-step testing methodology, you can see that there was a dramatic decrease in total cases and actually a trend downward in cases as well. Not entirely probative, but pretty substantially suggestive that when you do two-step testing, you're going to, from a laboratory basis, you're going to diagnose quite a fewer number of cases. Many places have an algorithm for testing. This is just an example of one. This is the one at ANMC. And so we say, is there 3 or more stools? And then as a patient over 2, just like we talked about, then we actually talk about symptoms. Is there any symptoms like fever, abdominal pain, white count, anything? Because many patients with C. diff do have those. And then next we ask, have there been antibiotics recently? And if there's no recent antibiotics and there's really virtually no symptoms other than some loose stools, we feel the likelihood of C. diff is pretty low. This is just going to minimize this testing. And then we also do ask, like, is somebody on Miralax or on tube feeds and they just got diarrhea from tube feeds? And otherwise, we do test them. And we have the same algorithm with a PCR positive and toxin positive or negative, and then what is our recommendation for what to do, recognizing that if a patient is negative for toxin, but PCR positive, they still might be sick, and we're going to talk about this in a minute, but they also could just be colonized and have C. diff in the intestinal tract, but it's not causing mild disease. Okay, so we'll get back into a little bit more about that in a minute, but now let's just talk about how do we minimize or prevent C. diff. So, pat on the back, hand clap for ourselves. Guidelines say that we should use antimicrobial stewardship programs to minimize use of high-risk antibiotics. Our focus on quinolones, clindamycin, cephalosporins is similar to what the guideline says. As a small example, we favor amsulbactam over ceftriaxone. There is some rationale that that drug is less C. diffogenic, but there are many examples that you can try to just nudge prescribing to regimens that are safer. There is very conflicting data regarding probiotic prevention for C. diff. So the IDSA and the American College of Gastroenterology and the European Society do not endorse using probiotics to prevent C. diff. I'm going to show a little bit of the data just to recognize that it's mixed. And then there's also inconclusive data about giving vancomycin enterally to prevent C. diff in certain high-risk patients, such as those that have had C. diff recently or on high-risk antibiotics or stem cell transplant patients. Many small studies suggest that there is a benefit if targeted, but this is not routinely recommended, and each facility can make their own determination on this. So this is from a study on global C. diff epidemiology, and there are many different charts and studies that have slightly different attributable risks of C. diff depending on the antibiotic. But as a general principle, tetracyclines, macrolides have low attributable risk, whereas cephalosporins, carbapenems, and typically quinolones have higher attributable risk. Interestingly, in this series, there was not so much attributable risk compared to the other combinations. But the main take-home point here is that not all antibiotics are similar risk. So when we talk about probiotics for prevention of C. diff, this became a bit more exciting when Cochrane published a review. Can't remember the exact year, 2017, somewhere in there, perhaps a little earlier, that lumped together many studies of various qualities using various products at various doses, and then suggested that there was an overall decreased risk of C. difficile diarrhea when you lump all those studies together. But you can see that the vast majority of those studies did not show a statistically significant improvement or reduction. However, 2 larger studies more recently have kind of pushed the needle the other way and are quoted in the guidelines as rationale for not giving probiotics routinely to prevent this. This is the Placide or Placid trial. This was double-blind, randomized, placebo-controlled, and was specifically trying to ask this question. And they used lactobacillus and bifidobacteria, and they saw no statistically significant difference in C. diff diarrhea. And in fact, there was just like maybe a subtle trend, but did not really come close to meeting statistical significance. Then the other trial that makes me concerned is a large trial in the ICU, thinking that probiotics might minimize ventilator pneumonia. And when they did this study, they looked not just at ventilator pneumonia, but one of their secondary outcomes, of course, was Clostridium difficile infection of any type. And they saw not only did giving probiotics in the ICU not reduce ventilator pneumonia, but it also had zero effect on reducing Clostridium difficile in the ICU. But concerningly, what they did show is a 14 odds ratio, so about a 10 times risk of culturing lactobacillus out of a sterile body site in patients in the ICU. So 1% of patients versus 0.1% of patients in the placebo group ended up either with lactobacillus bacteremia or lactobacillus in a pleural fluid or other sterile body fluid that was making them sick. So that doesn't seem good. Anytime there's no benefit and clearly demonstrable harm, we typically want to avoid those interventions. So we have moved away heavily from doing this, whereas we did tepidly do this in our hospitals for some years. So let's look at treatment guidelines. These are from the IDSA in 2018. I'm not going to belabor all these points, but basically the guidelines stated that vancomycin or fidaxomicin were appropriate for initial treatment, except for fulminant disease, vancomycin plus metronidazole is the drug. And then for recurrences, vancomycin with tapers or fidaxomicin were considered appropriate, which we'll talk about in an update in a moment. In 2018 for pediatrics, basically metronidazole or vancomycin were given initial sort of equivalent force and effect. Most children don't get overly ill from this, although children with hematologic malignancy certainly can. We've really moved to using more vancomycin in children. Now in 2020, fidaxomicin was approved age 6 months and above. So this is the dosing table from the FDA approval. And there is dosing in a liquid formulation for children that can't swallow capsules or tablets. But these are not incorporated into most guidelines. There's just really not data on superiority over the other regimens in children. And so it is an approved and FDA reasonable approach, but I don't know what the IDSA or other guideline panels will do on their next update, but it remains an option. And we're going to talk more about fidaxomicin versus vanco in a bit. Now, I alluded to this earlier, but this is a question that we get many times, maybe each month. What if the stool NAT is positive, but the toxin is negative in the stool? So the whole reason that PCR testing was developed 20 years ago or 18 years ago for this is that the toxin EIA, that's an enzyme immune assay, it's a very cheap and easy test, but the sensitivity is poor. It's about 50%. So that means that the negative predictive value is only about 2/3 in most cases. That suggests 1/3 of cases that are truly having diarrhea from C. diff will be missed if you decide whether to diagnose somebody solely based on a toxin. And that's shown in one study here, and there are many similar here. But if you compare the Illumigene assay to the EIA, you see that sensitivity and specificity are poor. So what we typically say is if a patient is ill or has high suspicion for disease, even if the PCR is positive, but they're ill and or you have a high suspicion for disease, the patient should be treated, because 1 out of 3 times they will have C. diff and you're not treating them. Now, if they have very mild diarrhea, they're getting better on their own, you have low suspicion, it's probably okay to not treat them. And in fact, most of the time, we hope people won't be treated. But if they meet those typical criteria, we do treat them. Now, I just heard in a meeting this morning that the reporting agencies are probably catching on to all this, and recognize that many patients with a negative toxin end up getting treated in the hospital. And those cases may end up being reportable in the future, which is probably appropriate, frankly. But this is just to say that we should never use a single lab test to make a clinical decision on a patient. Now, in 2021, there was a treatment update from the IDSA addressing just a couple things. And the first thing they did was recommend that fidaxomicin was favored for an initial episode, but that vancomycin was still acceptable. And there's reasons for that. So most facilities develop an algorithm when you choose fidaxomicin over vancomycin, because vancomycin this month was $46 for a 10-day supply with the GoodRx coupon. But the GoodRx coupon wasn't too helpful for fidaxomicin, which was $5,147 for a 10-day supply. Now, most insurance will pay for that, and people pay a copay or whatever their program pays, but it's still extremely expensive. And that's just it's a 100 times difference in cost. The main reason to favor fidaxomicin is for recurrence prevention. So there is dosing that can be done either 10 days twice a day, or 200 twice a day for 5 days, then 200 every other day for 20 days. And vancomycin taper is an alternative. So for a recurrence, fidaxomicin is favored, both for those having recurrences, because it reduces the risk of recurrence. I'm going to show some data. The other thing the 2021 update did was mention that besletoximab infusion could be added if a relapse in the last 6 months to reduce relapse risk, but this was pulled from the market in January. The manufacturer has not said why. They probably just weren't selling much of it. It was extraordinarily expensive. I think it was $10,000 or $15,000 for a dose. So the data on fidaxomicin over vancomycin, I just want to show you here, this is what was cited in the studies or in the guidelines, and it's actually pretty poor. You can see that the global cure rate for fidaxomicin versus vancomycin in this study was minimally different. This slightly improved, but a little bit better. The main driver of this is for recurrences. So this study, called the Extend study, was 364 patients, and they actually showed that the initial clinical response was the same between vancomycin or fidaxomicin, and the difference was that the relapse rate was higher in the vanco group. However, they compared the extended dosing of fidaxomicin, 200 twice a day for 5 days, and then once every other day for 20 days. So basically a fidaxomicin taper versus standard vancomycin therapy. They didn't compare fidaxomicin taper to vanco taper. However, they were able to publish this and show that there was about 15% reduced risk of relapse when using fidaxomicin versus vancomycin. And it's a strongly p-value, so they got a lot of attention from this study, and it does fit with the microbiology because fidaxomicin treats virtually no anaerobes, so the gut retains a lot of anaerobic flora, and vancomycin surprisingly kills a lot of anaerobes in the intestine, even though we don't think about it as an anaerobic drug. And so fidaxomicin retains the microbiome a bit better. But the bottom line conclusion to the data is really that fidaxomicin may reduce relapse risk. It's not superior for acute disease or for severe disease. So this is what we do at ANMC. A lot of places do something similar. You can put your attention to the middle of the page. But basically, we say for antibiotic selection, is the patient very sick, yes or no? And then if they're very sick, then we give vancomycin, because that's what the guidelines say, and there's no benefit to fidaxomicin for treatment. But if they're not very sick, however, they're a high risk for recurrence, immune compromised or over age 65, that's where we favor fidaxomicin versus vancomycin to reduce the relapse risk. And then for recurrent disease, we do favor fidaxomicin because it does appear to minimize the risk of relapses. Okay, so then what do we do if somebody is repeatedly relapsed? Because I'll just go back to this for a second. So, recurrent C. diff, refer to fecal microbiota transplantation after second recurrence. So if people continue to relapse, that's where we think about reinvigorating the GI flora by a transplant. Well, how do we do that? Historically, it's been empathetic family members who want to donate their own stool to other family. That's how it was first studied, and New England Journal published that about 17 years ago. But we don't do that anymore. So we have now, because we have FDA approved mixtures, that's what actually we have to use in any accredited institution is approved mixtures. There's two things. So you can use this stuff called Rebiota, kind of catchy name. It's an enema formulation. The 8-week success of this in the licensing study is 62% that got a placebo enema without stool in it, had a 62% response rate and didn't have another relapse. 71% that got the enema had no relapse. So there was about 9% improvement. There are meta-analysis of 4 studies that does show the p-value 0.017 for transplant. But again, 62% that got placebo, 71% that got enema had a relapse. The price is $9,000 for that product. The other one that is FDA available is called Voust. We are colloquially referring to this as crapsules because it comes in a capsule formulation and it's poop in there. The way you do that one is you have to give a laxative and a fast for 8 hours, and then you take 4 capsules daily for 3 days. I believe they're breath mint flavored, these ones. And so in this, they actually had very similar data. They had an 8-week success rate of 60% in the placebo group. So those that had multiple relapses, they got placebo crapsules. 60% didn't have another episode, but 80% that got the oral microbiota did not have another episode. So it was more efficacious. The wholesale price is $18,000. That is some expensive crap. But this is what is available to us in current times. And so that's really just, I think, basic summary of what I wanted to say about updates in C. diff just over the last several years. And I suspect there may be some questions on this stuff. So here's the references, and I'm going to go ahead and just stop sharing and see if hopefully a few more people have gotten in. I know we're having these issues, but just see if anybody's got questions.
You know, Dr. Westley, Noelle from Cordova listened to the last part over the phone because she had some specific questions. So I'm going to see if we can hear her and if she can relay any of those questions she had reserved. Noelle, can you hear me?
I can. Okay. Yeah. Can everyone hear me?
I think so. Dr. Westley, can you hear her?
Yep.
Yeah, go ahead, Noelle.
I wasn't able to hear your whole presentation, so I apologize if this came up earlier, but we're having trouble in our LTC where folks that we have treated now, we're on the 3rd go-round of treatment, and with fidaxomicin continue to have diarrhea, although they don't appear sick, and it is decreasing in frequency. And we just don't know when to end this, you know, and to have her, you know, what point to ask for a IV consult from ANMC, because this is this person has benefits there. And yeah, do you have any guidance around ongoing diarrhea?
Well, if somebody's had 2 independent relapses and then has another one, that's typically when they would get referred for fecal transplantation. Maybe after the first relapse, so a 3rd case or a 4th independent episode. When people are treated, the diarrhea should go away, and then when you stop the treatment, it comes back very quickly, oftentimes within days or a week. Certainly virtually always within 30 days. So if this person is getting better each time and then relapses, it sounds like they would meet the usual next step of microbiota transplantation. So would use the fidaxomicin with the extend dosing 200 twice a day for 5 days and then 200 every other day for 20 days. But now that there's FDA approved products, it may be easier to move the product to the patient than the patient to the product if they're in Cordova.
Okay. And there was some concern about the type. So one of her previous courses was Ginkgo. I think we had a capsule with powder that we were putting in her blood tube. And then there was later on, there was some research and some concern that maybe this wasn't the best. We should have done liquid instead of the capsule based off some concern for absorption. Do you know about, best practices for PEG tube treatment?
No, I don't. But if it's a specific patient with native benefits, maybe you can give Katie a call over at Native too, and we could coordinate on a specific patient issue.
Oh, yeah, she said thanks. I don't know if you heard that. Anything else, Noel?
No, that's it. Thanks, Debbie, and thanks, Dr. Westley.
Yep, no problem.
It looks like there's also a question in the chat there, Dr. Westley.
Do I have a theory as why placebo enema is 60% effective? Yeah, because after a second episode, the likelihood of a third episode is about 50%. After a third episode, the likelihood of a fourth episode is it's about 50%. So a placebo enema is going to be effective about 50% of the time, in this case, 60%. There's really no prep to the enema. The enema did not require any kind of laxative prep or anything else like that. So I think, just because somebody's had 3 episodes doesn't mean they're going to have 20 episodes. So eventually they're going to, even without fecal microbiota transplantation, probably most people will eventually not have episodes, but it's a miserable process. So by the 3rd episode, most people just want it over. And if you can increase the likelihood of not having another episode by 10 or 20%, which is kind of what the best data is. I think the reason I wanted to point this out is because 15 to 20 years ago, fecal microbiota transplantation was really thought to be like some type of silver bullet, new heralded like miracle cure. And the best available data is that it's appreciably helpful, but it doesn't cure 95% of people. And it's not that everybody that doesn't get it at that point isn't going to get better. So I think that's the important things. And it's extraordinarily expensive. However, so is fidaxomicin. I mean, a 10-day course of fidaxomicin is $5,000. So you could say it's expensive to do an enema for 10 grand or crapsules for 20 grand. But also, if you have to keep giving them fidaxomicin, you're spending $5 grand every 10 to 30 days, depending on 10 to 25 days, depending on how you dose it. So.
Great, thanks. Any other questions for those that made it on? We have to figure out why we all made it on and no one else did.
Yeah, Dr. Westley, this is Shauna. I think you briefly talked about prophylaxis with the A&MC table you showed earlier in the presentation, but I missed it. Will you tell me what do you currently here at PAMC? We give prophylaxis, we give VANC 125 BID for patients who had a recent infection in the last 90 days and are on a high-risk antibiotics. And but we also have times when like oncology or different places want to give it for immunocompromised patients, which I think is what A&MC does. And they're giving fidaxomicin instead. Is that correct?
I don't think so. You're talking about just a cancer patient who's never had C. diff before that gets put on cefepime?
Yeah, I guess I'm just asking for what are your current recommendations for the prophylaxis piece of C. diff?
Yeah, well, I think what we're still doing at Prov is okay. We haven't formally changed that. If somebody had C. diff, especially in the last 30 days, and you're putting them back on cefepime or meropenem or something, they have a high chance of having C. diff again. So I think what we're doing and trying to keep the rates down is it seems okay because there is data to support that. Although the national guidelines are not really favoring that as a global rule. Katie, is Katie on here? She might not have been able to get in.
I didn't see her last time I looked at the list.
Yeah,
So what
I
about
don't,
patients who are NAT positive, toxin negative, but don't have a recent history of an infection? What do we do with that scenario?
if they're on, and they're on well, if they're on antibiotics and they have diarrhea and they're PCR positive and toxin negative and they're on a high risk antibiotic, they probably have C. diff.
Right. Okay. That's what I usually recommend it in that scenario. I'm not recommending it in patients just because they're immunocompromised though.
No. There's no data for that. There was a recent study a couple months ago that looked at stem cell transplant patients. I mean, you're talking about really high risk patients that we don't have in Alaska, like a BMT or a stem cell transplant patient and probably in hospitals that actually had a lot of C. diff in those units, and that those patients that got broad antibiotics, there seemed to be maybe a benefit in prophylaxing them, but that doesn't really apply to our population. And I don't, maybe email Katie and see if we updated our prevention stuff at NMC, because I think we did back off a little bit over there at some urging of everybody over there, but I don't remember what we have, but Katie can send it to you.
Yeah, and I'm actually pulling up her stuff right now. It's still online.
Okay.
I guess we get stuck in that gray area a lot. Patients who are NAT positive, toxin negative, they obviously had diarrhea because that's why they sent a stool to them. But if they don't have signs and symptoms of like white blood cells are normal, there's some like, should we still treat them with the VANC QID? Like treat it? I guess it's clinical decision at that point, right?
Yeah, if somebody's diarrhea is getting better, they're not sick, and they're not on meropenem or something, you could call them colonized. But it's just important to recognize that the data says that 1/3 of people that are PCR positive, toxin negative, or their diarrhea is from C. diff. So it's just important to know that. So if they're sick or they're on an antibiotic that's probably causing C. diff and they're troubled by their diarrhea, it's probably from C. diff. But it's 1 out of 3, globally. So that's why it's a clinical decision. And it sounds like NHSN is going to start dinging us on the ones that get treated when they're toxin negative, and they probably should, because if somebody's on meropenem and has diarrhea and cramps and they're PCR positive and toxin negative, and you give them 10 days of ANCO, they probably got C. diff.
Yeah. Okay. We tend to err on the side of treating, and I just wanted to make sure that's what we still should be doing. Thank you.
Thanks. I'm glad you were able to get on. Any other questions? Feel free to come off mute. It's a small group. So while you're thinking, my plan is to send this recording with the slides out right after I get that. Hopefully Zoom was able to record it. I'm assuming they were. Is it all right if I put your email and maybe Katie's in that as a follow-up for questions about, if they have questions about this once they watch the recording?
Oh yeah, I'm okay with that. I'm okay. I don't want to speak for Katie if she's not here, but for me, it's okay.
Okay, I'll put yours in, and then if someone has something specific for Katie, reach out to me. And yep, I think doesn't look like there's any other questions, so I think we can sign off. Great information and great series, Dr. Westley. We're making YouTubes of all of them so that they'll be available, all the sessions, to anyone in Alaska over the coming year until we need to do a refresh update. So
sounds great. Thank you.
Yeah. Kristen, any other last words?
No, the series has been great. I did put the link to the CEUs in the chat. Hannah tells us we have till May 1st to obtain those, so anyone can go in and get those CEUs up to May 1st for any of the sessions.
And if you watch the recording today, still feel free to go in and complete that CEU and get your credits. That's fine to do that. So, well, thanks, Dr. Westley. We appreciate it. And we'll talk to you all soon. Let us know if you have any other questions.
Okay, thank you guys.
Okay, bye.
Bye.